Welcome, everyone. Welcome back to our IVF webinars and my IVF answers. I'm glad to be here once again with all of you. And again, I'm also very excited to see what Dr. Andreas Abraham has brought to us tonight. This is going to be an interesting session. Dr. Abraham, thank you so much for joining us once again. It's lovely to have you here. I hope you are well. How is it going?
Hi, Caroline. I'm good. Thank you. Thank you for the nice introduction. I'm excited to come back. COVID has been challenging, but for me, I think the rest of us, it's almost over. So I'm very positive and happy to be here again. So let's get it on.
Yes, thanks so much again. It's lovely to have you. And let me just mention, if you haven't seen Dr. Abraham yet, he's the head of Eugin International Clinic, which is located in Barcelona. Dr. Abraham has many, many years of experience, and tonight he will discuss and share his own experience. He will share his patient stories, success stories, and we will discuss genetic issues most of all. So we will start with Dr. Abraham presentation, but afterwards, as always, remember, it will be time for your questions. You can do it during this presentation. You can put them in the chat section, or you can do it, during our Q&A session. It's going to be interesting session. I am sure of this. And let me just also mention that my IVF is a part of European Fertility Society. There are many things going on, and we are planning many things to support patients, but also clinics, organizations, simply because we want to help as much as possible to this community. We know how hard that can be. And with those webinars, this is our first webinar, and this series will be, we will be talking about success stories. We will focus only on real patient cases. Tonight it's genetic issues, but tomorrow we'll talk about recurrent miscarriages. We will also talk about advanced maternal age. So I can only encourage you to sign up. It's going to be interesting. We had many webinars before, based on various topics, but we are very excited about this project because it's all about real cases. And I think it's going to be interesting for lots and lots of patients, where they can either relate or they can simply see what can be done in their similar cases, I'm sure. So thanks a lot for joining us tonight. It's wonderful to see some of the familiar faces here as well. And now, that is it from me, I promise. I think it is time to start our webinar, okay? And presentation, of course.
Excellent. Thank you, Caroline, again for the nice introduction. And hello, everybody. Good evening from Barcelona. Caroline has already introduced me. So, I'm working in the Eugin clinic here in Barcelona. It's been already 14 years. I'm originally from Germany, German born and trained, but it's been 14 years living and working in Barcelona, and working at Eugin here in the headquarters in Barcelona. So as you have seen in the program, I was asked to give a talk on genetics, and in particular on embryo testing, which is a very important and interesting topic, and a topic that is basically key in almost every first encounter with the patients. You have to know, obviously, before we go into the case studies, some basics. I'll keep it short, but you have to have some basic information before we dig into details. So if we talk about testing of the embryos, the term is PGT, pre-implantation genetic testing. And this began as an experimental procedure in the 1990s, so it's quite some while that it's around. And it started, and is still, it started with PCR, polymerase chain reaction. All of us now know through the COVID pandemic, because The COVID test, it's done by PCR, where we try to detect a tiny fraction, a little amount of virus DNA. Obviously, in terms of embryo testing, we look for much bigger amounts of DNA. What you need to know is that there are three different types of PCR. The PGT-A, A stands for aneuploidy. Here, this term was formerly known as PGS. A lot of you might know it as PGS, pre-implantation genetic screening. Now it's called PGT-A, A for aneuploidy, meaning this test checks the embryos for abnormalities in the number of chromosomes. Embryos with an abnormal number of chromosomes are called aneuploid, and they, depending on the type of aneuploidy, may be responsible to have less chances of developing a healthy pregnancy that results in a baby born without any genetic problems. Then there is PGT-M. M stands for monogenetic disease. This is the testing of the embryos, which is indicated if in a family or one of the two partners, or maybe the two partners, have a disease that runs in their family caused by a specific single gene mutation. So there we test the embryos specifically for one gene, and then can identify the embryos who have not inherited the mutation, the healthy embryos. The third form of PGT, of embryo testing, is the PGT-SR. SR stands for structural, and that's embryo testing when we know that one of the partners, or sometimes even both of them, have structural rearrangements, meaning that the normal size or arrangement of chromosomes is affected. We know that people with these structural rearrangements are more prone to have or to produce embryos with incorrect amount of genetic material, which can cause problems to implant or recurrent pregnancy loss. Here, just to visualize a little bit the term aneuploidy, as I told you, the normal set of chromosomes, the normal number of chromosomes for us humans is 46. We have 46 chromosomes, XX for a woman, XY for a man. And here you see in the middle, you see the situation where one chromosome is missing, which is called monosomy. So we have a total of 45 chromosomes. And on the right, you see the situation where there's an extra chromosome. It's called trisomy, and we have a total count of 47 chromosomes. The most commonly known form of trisomy is trisomy 21, also known as Down syndrome. Very important, before we again get to the cases, is that you are aware that we cannot just test embryos at whatever stage. So I compiled these obligatory steps or conditions for a properly performed embryo biopsy to test embryos. It is that something we know now. We didn't know that in the 1990s, when the whole journey for the PGT, PGT-S began. Now we know it's obligatory to perform the biopsy of the embryo at day 5 or 6 of the embryo development at blastocyst stage. At this stage, 6 to 10 cells are taken from the outer layer of the embryo, the so-called trophoectoderm. That's the part that later develops into the placenta. The inner cell mass will form the fetus. Testing of the embryos goes along with having no fresh transfer. So we have to freeze all the embryos to await the test result, which usually takes around 2 weeks. After that, the transfer will be performed as a cryotransfer in a consecutive cycle. You have to be very aware that the whole process will result in a reduction in the number of transferable embryos for various reasons, and you'll see that in the following. And also important to know that the value of PGT-A in particular, formerly known as PGT-S, is still under ongoing discussion. Yeah, but this is outside the scope of this talk. And here, and that's also important to have some basics. The guidelines, the ESHRE, that's the European Society of Human Reproduction and Embryology, gave out best practice recommendations for PGT-A. And they defined 4 main indications where PGT-A is used. First one is AMA, advanced maternal age. Second one is repeat implantation failure. The third is repeat miscarriage. That means that a woman has 2 or 3 consecutive miscarriages. Important to know in that context that here ESHRE does not recommend a PGT-A in its latest guidelines. And the fourth indication would be the severe male factor. ESHRE specifies that the exact definition, age limit, number of pregnancy losses, number of attempts to qualify for repeat implantation failure should be determined by each center based on their numbers. And they also, that's common knowledge, remind that for any type of PGT, a karyotype testing for both partners is obligatory in the pre-technique workup. That's very important to know. We'll now look into, and as promised, we'll go to the clinical cases in just a moment. The definition and the use of PGT-A in advanced maternal age. The definition of advanced maternal age is varies. Some publications define advanced maternal age from 35 onwards, some others from 38 onwards. All studies talk about good prognosis patients, and that means that these patients have at least 10 M2, means 10 mature eggs, and at least 3 high-quality blastocysts. And then these studies state that PGT-A under these good prognosis conditions is likely to improve live birth rate in the first transfer, is likely to reduce the number of transfers necessary, and at the same time, one has to critically tell patients that there is no data on the cumulative live birth rate, and there's no data on time to pregnancy. So the conclusion there is, if you use PGT-A in patients who are not fulfilling the conditions for good prognosis, having a lot of eggs and having a lot of blastocysts, you might not do any good. You might not increase live birth rate and time to pregnancy. Then the use of PGT-A in repeat implantation failure. There, if you look at the data, there's not sufficient data to really support that. And again, studies who promote this have used patients who have had a lot of embryos, 6 high-quality blastocysts or more. PGT-A in repeat pregnancy loss or repeat miscarriage. There, if you look at the clinical evidence, there's not a lot of data, and there's on top of that conflicting data. That's why ESHRE, as I told you before, tells us that the use of PGT-A for this indication has to be looked at in a case-to-case basis. And they state that expectant management, doing nothing, no invasive technique, may be as effective as PGT-A. And same thing, studies to support the use have had selected patients with a high number of good quality blastocysts. So then, if you use PGT-A in women of young age, under 35, women with good prognosis, you need women again, and most young women will have a good number of eggs, and therefore also a good number of embryos. And here, PGT-A, PGS is most likely responsible for decreasing or reducing time to pregnancy. The data, again, is not, there's not a lot of data to support that. And the data which is there, again, relies on very good prognosis patients, and there's no data on time to pregnancy. Now, finally, and I'm sorry that you needed these basics to really have at least some basis to understand why some doctors, some consultants, and some clinics promote and use PGT for the different indications. Here, it comes finally, the first clinical case. This is a case of our clinic in Barcelona. It's a 42-year-old single woman who came to see us to perform an IVF with the own eggs and donor sperm. She she asked explicitly to use PGT-A since she has had advanced maternal age, and she experienced repeat miscarriages. She had 4 pregnancies and miscarried 4 times. And now I want you to, I'll give you some details, and they're important, and I'll will explain everything bit by bit. So we did a stimulation, and high dosage stimulation with a high dosage of FSH, and she produced a good response at the punction, at the oocyte pickup. We could retrieve 15 oocyte cumulus. After washing, we saw that 13 of them were mature eggs. And then we performed ICSI, and the next day we saw that 11 of the 13 had been fertilized. This, in terms of quantity, for a 43-year-old woman is a very good result. And if you remember the basics that I told you before, this woman complies all criteria for a good prognosis, advanced maternal age patient. In the end, 5 embryos developed till day 5, where we performed testing. So we did tests on 5 embryos. After 2 weeks, we found or got the result that 2 embryos were normal, 3 abnormal, and none of them were mosaic. Then we performed a single embryo transfer. ESET stands for elective single embryo transfer at day 5. And we've vitrified the remaining embryo at day 6 of its development. It was an ongoing pregnancy with a slightly preterm vaginal delivery at 36 weeks. So this first case is representative for a big fraction of our patient population. For you, it might be interesting to know that over 50% of our patients who come to see us for IVF with their own eggs are over 40. But a very small fraction of these patients will have such a good response to stimulation. And if you remember what I told you, in the initial slide, it's obligatory to do the biopsy at day 5. So this patient is a textbook example for a good prognosis, good response patient. And yes, this went well. But we had a big, high number of good quality blastocysts with it, which is not the case in most of advanced maternal aged patients. Very important to remember. The next clinical case is a case where I want to show you the indication or a classical indication for PGT-A in IVF. It's a 30-year-old patient, a heterosexual couple, where we performed IVF plus PGT-A for the indication of repeat miscarriage and a severe male factor. This patient had 5 pregnancies and she miscarried 5 times. In total, they tried 3 years to conceive, naturally and with help of IVF. We did a stimulation, hyperstimulation with FSH. We retrieved at the day of the oocyte punction 26 cumulus cells, so high number. After washing, 21 mature eggs. After injection of the sperm, the partner sperm with ICSI, the next day we had 17 fertilized eggs and 9 embryos developed till blastocyst stage at day 5. After testing, we had 3 normal embryos, 4 abnormal, and 2 mosaic embryos. We performed an elective single embryo transfer at day 5 and vitrified 2 remaining embryos. This is an ongoing pregnancy. She's currently entering the 3rd trimester. And here, this is a classical case, where we used PGT-A, formerly known as PGS, for indication of repeat miscarriage and severe male factor, complying with the ESHRE recommendations. And again, here, I want to lead your attention to the high number of embryos, the good prognosis patient, young, under 35, with a good ovarian reserve, a good response. So it's quantity, egg quantity, consecutively that translates into embryo quantity and quality. And you see, and that's something which is crucial, I want to lead your attention to the reduction in number. So we started very high with a high number of eggs, and every step of the way, the number declined. And we finally arrived at a number of 3 normal embryos, which is a big reduction. And remember what I told you in the beginning? One has to prepare the patients for this reduction in quantity, and that might as well be the limiting factor for a lot of our patients, especially in advanced maternal age. This here is a young woman, a young patient who has no limitations regarding age and limitations regarding egg quality. Next clinical case. Here, I'll give you the example for PGT-M. M, as you might remember from the initial slide, stands for monogenetic. This is an embryo testing we performed in a heterosexual couple, young patient, 29 years, where the male partner had Marfan syndrome, which is a monogenetic disease. And here we had a couple who were trying 2 years to conceive. They had one spontaneous pregnancy that was a termination of pregnancy due to the genetic monogenetic underlying problem. So they contacted us to perform an IVF with PGT-M. High dosage stimulation, good response, 25 retrieved eggs, 21 were mature after washing, ICSI, and we reached day 5 with 6 embryos, 6 blastocysts. After biopsy, we found 5 normal embryos, 1 abnormal embryo, and no mosaic embryo. We performed a single embryo transfer and froze, vitrified the 4 remaining embryos. It is currently an ongoing pregnancy in the 2nd trimester. Again, it's the same concept, and you see some sort of system there. It's another indication. Yeah, it's a monogenetic disease. Young patient, good prognosis patient, since female patient is young. She has good response to the stimulation, high number of eggs, good fertilization, good embryo development, and in the end, 5 normal embryos. But you see, again, 5 normal embryos. To have 5 normal embryos, we started with 25 retrieved eggs. Again, the reduction, which is important to stress out and remember in the context of patient counseling. The 4th case is an example for the PGT-SR. SR, as you remember, stands for structural. Here, it's one of the most common structural rearrangements in humans. It's the so-called Robertsonian translocation. It's a young heterosexual couple where the male carries the Robertsonian translocation. The patient is 29 years of age. She had 4 pregnancies, miscarried 4 times, total of 2 years trying to conceive. High stimulation, very good response, 32 retrieved eggs, 29 of them were mature. After ICSI, 25 fertilized, and 7 embryos developed until blastocyst stage. 4 were tested normal, 3 abnormal. We did a first single embryo transfer, which resulted in a biochemical pregnancy. We did a second cryotransfer, which resulted in an ongoing pregnancy and delivery by C-section at 36 weeks. Same situation, same concept. You see the high number of eggs and embryos which are necessary to arrive to the end of this process. Yeah? And these 4 cases cover the 4 or the 3 indications for PGT. I chose 2 textbook examples for PGT-A, the formally term PGT-S, to explain the main indications for these techniques. Yeah? And obviously, there's variations of the same theme, but I try to give you textbook examples to have a more solid understanding of the differentiation in indication and execution of the cycles. And as the main take-home message, I want you to remember the massive reduction in the number of transferable embryos that go along, that are intrinsic with this technique. And obviously that can result, now I gave you, and I was asked to give you success stories, but obviously you can imagine that sometimes we perform PGT and we do not have any embryo for transfer, be it because no blastocysts develop, or all embryos were tested abnormal. And that is something that can be the case. And that's something patients have to be made aware of before they can take a decision. So it's a crucial part in their decision-making process. And with that, I thank you for your attention. And obviously, now we have time to discuss and ask questions. And in case you don't feel confident to ask questions in this setup, there's no problem to contact us directly. We do second opinion consultation without any problem, because this forum might not be the best forum for very detailed questions. But again, I'm here to respond. I'll try my best, and I give it back to Caroline.
Wonderful. Thank you so much, Dr. Abraham. That was amazing presentation. Thank you so much for explaining things first, and then you went for the clinical cases. Definitely, it's good to see how it all works. And now it is time for your questions. As Dr. Abraham mentioned, of course, you can ask anything right here, but if you feel that you would like to get some more details, I'm sure there is a possibility for you to get some advice from him so, at the clinic, etc., of course, as well. So don't hesitate. And as you can see, Dr. Andreas, there are like some questions, like 3 of them right now. So let's get to them, okay?
Okay.
Here's the first question we've got. I am 39, have AMH of 21.5 picomoles and had 2 IVF cycles. The first resulted in total fertilization failure with 9 eggs retrieved, and the second one resulted in 2 grade A blastocysts from 6 eggs retrieved, ICSI. Unfortunately, I had a miscarriage from the fresh transfer at 10 weeks. Would you recommend PGT-A in my 3rd cycle with my own eggs? Thank you so much for the very first question.
Okay. All right. So you're 39. Remember, I said, depending on the publication and the authors, the definition for advanced age starts at 35 or 38. You have a good ovarian reserve reflected in a good AMH. You had a normal response in your first, obviously unfortunate fertilization failure. You had 9 eggs retrieved, which is not a lot, yeah. And the second one went better, since at least the ICSI kind of did the trick, and you had 2 blastocysts from just 6 eggs retrieved, which is actually a very good ratio. So not knowing how you were stimulated, yeah. Obviously, one has to dig a little bit deeper also in the protocol. I suppose you have been highly stimulated with a high dosage. Sometimes you can play a little with the triggering. There's double triggering which can up the outcome of the harvest of a number of eggs. For the 3rd cycle, yeah, with the limitations I told you, you would, yes, be candidate to try PGT-A. One would have to be very, very frank and have a little bit more information. But as you saw, what I told you, my focus one was on the number. So you had 300 units of menopause, perfect. That's what we would have done as well. So that's good. I suppose so. Yeah. So in your case, since the second time, you actually had a very good outcome, out of just 6 eggs, you produce 2 blastocysts. The PGT-A could give us additional information, but one has to be aware, and that I didn't touch that topic today, because that would be a topic for a second separate talk. Actually, I didn't touch the topic of mosaicism. In your 3rd cycle, I would recommend to have a thorough visit with your IVF doctor to dig a little bit deeper into what I try to scratch on the surface, with adding the topic of mosaicism, because doing PGT-A in your case can give us additional information, but it can reduce the number of transferable embryos. So I would consider it as an option, since you didn't hit 40, you have you had a rather good response, and obviously one would not consider conventional IVF in your case, since ICSI gave the better result in terms of fertilization and blastocyst development.
Thanks for the very good question, and of course for your thorough answer to that. And of course, as you can see, thank you so much from the patient for your right here as well. And let's have a look. There is another question coming up right here as well. And let me just go back. I think I missed this. Yeah, here it is. Sorry. I am 41, had a miscarriage 2 years ago, started IVF this year doing embryo banking, have had 4 rounds so far with mild stimulation, have frozen 2 day 3 embryos grade 1. I'm planning to try a long protocol next time. What is your advice in terms of protocols? My AMH is low, was 3.59 picomoles last year in March, and FSH 2.6. Also, would you recommend more rounds of IVF before proceeding with the transfer? And let me just go to the second part. My stimulation was with Clomid, and for 150 units of menopause, long protocol will be deferraline, on day 21, and thereafter gonal F and menopause.
Okay. All right. So it's a complex question, but to kind of structure, your advanced maternal age, 41 years old. The approach to do mild stimulation is perfectly okay, but obviously, actually, that's the approach that was is common protocol in Japan. In Japan, Dr. Kato, he basically invented vitrification technique for his protocol. They believe in mild stimulation or natural cycle, no stimulation, and then they believe in egg banking until they have. So they do every month, they bank the eggs, and then after 6, 7, 8 months, they inject and produce 1 or 2 blastocysts. That's one extreme. Here you performed embryo banking. You had 4 rounds of stimulation, and you have 3 embryos grade 1. Remember what I told you. It is common knowledge now that PGT should not be performed in day 2 or 3. So I don't know what the plan is. If the plan is to compile embryos at day 3, and then if there are sufficient number of embryos at day 3, to try to bring them to blastocyst stage. That's one thing you have to bear in mind. That's a question you have to ask the laboratory. Every lab knows its percentage of blastocyst culture, so how many embryos they need to reach day 5. In our lab, we know that we need 4 to 5 top embryos at day 3 to reach day 5. So that's something you have to ask the lab, the doctor, the IVF clinic you are under treatment. And then the last part of the question, would you recommend more rounds of IVF? before proceeding with the transfer. Well, that goes, it's intrinsic in the strategy to do embryo banking, to kind of compile a certain number before going for transfer. And remember, again, I don't know this clinic where you're at. With us, we do not do embryo banking usually. Yeah, in case on demand, if there's special patients who ask, we might do it. But again, what I told you, in our lab, I know we need 4 to 5 top embryos at day 3 to be able to reach day 5. And obviously, the limitations from 40 years onwards are that even, if there, in this case, one would rather need more to be on the safe side. It's not mathematics, it stays biology. And at 41 years, you're more prone to have fertilization failure, even if the sperm is perfect. You have more risk to have arrest of the embryo development. So all that is something to be taken account. And so, yes, all that is factors who speak for doing more rounds to compile more embryo quantity.
Excellent. Again, thanks so much, of course, for your thorough answer to this one as well. And there's a thank you from the patient for you, of course, here.
Thank you.
Okay, now there will be a bit of a shorter question. And remember, for now, at least, it looks like our final question. But of course, if you have more, you know what to do. Go ahead. Yeah. The question is, are mutations mostly related to age? Is it more secure to go through egg donation treatment than own eggs for 40+ patient?
That's actually a very, very good, very interesting question. I'll and you'll have I'll give you a rather complex answer. So during the talk and also during some of the answers, I mentioned that egg quality is linked to maternal age. Yeah? So maternal age is egg quality. Egg quality, in the context of reproduction, the egg is more important than the sperm cell. So egg quality translates into embryo quality. And embryo quality is basically responsible for implantation rates and for the health, the state of the embryo, the health state of the embryo. So most chromosomal abnormalities, chromosomopathies, are linked to maternal age. And yes, mutations are also linked to the egg and embryo quality, because you can imagine with age, on a cellular level, errors occur more frequently. So yes, maternal age is responsible for these events. And yes, consecutively, the conclusion might be to go for egg donation, because there obviously you kind of erase the factor age, egg quality. Using a young donor, average age of donors is 25, in Spain from 18 to 35. So you have a young donor. As I told you, age is egg quality. Egg quality is embryo quality. So using a young donor, you basically erase or minimize at least all problems linked to maternal age. And yes, this way you reduce, not to zero, but you reduce this problem. Bear in mind that even an 18-year-old mother, be it in nature or being an 18-year-old donor, could have a Down syndrome child. Yeah, it's not zero, but it's very, very low, the risk linked to maternal age. So you minimize these risks by using egg donation. Yes.
And again, thanks so much, of course, for explaining. Definitely interesting question. Thank you for answering this so, again, thoroughly. Let's have a look. One more question is right here. what is the most common cause of embryo non-evolution in women under 35?
Mm-hmm. That is also a very interesting question. I will start to answer going back again into nature. Yeah, nature. So imagine the perfect couple. Imagine a woman, donor age, let's say 22 years, no problem whatsoever. What I told you before, in the context of reproduction, being in nature, natural reproduction, or with IVF or whatever technique, the egg is more important than the sperm cell. So I'll talk about the woman, but this woman, this young woman without any problem in nature, she has the perfect partner with donor-like sperm. This couple, this woman will have various intercourse around her ovulatory date. Per month, per ovulation, this woman has just 20% success rate. Yeah, this is shockingly low, considering that's the best case scenario. That's the perfect couple. But nature, evolution, gave us a very ineffective reproduction. And so if this woman tries to get pregnant every month, after 12 months, we know she'll up her chances to over 90%. But 12 months, what does that mean? That means 12 ovulations, 12 eggs, and if there's fertilization, in the best case scenario, 12 embryos. So if you want, nature needs 12 months to up chances from 20 to over 90%. And that is part of the answer. So the most common cause of non-evolution, we actually do not know. It's still a black box. And obviously we can kind of do thorough testing. So we will, if there's, repeat miscarriage, repeat implantation failure, we will do karyotypes of the partners. We will do maybe even dig deeper into genetics, sperm fragmentation, and maybe we find something that can explain that. But the most common cause is exactly what I just told you. We do not know. Yeah, it's something we still don't know, and we are actually, if we look at other animals, we see that other mammals do a much better job. We have a rather complicated reproduction as humans.
Thanks again for interesting question, indeed. Let's have a look. Kat has added one more question here as well. Is it possible to do a double biopsy on the blastocyst in case of a false negative result in order to avoid damaging the embryo?
I have to. First of all, remember what I told you in the second or third slide. Usually at blastocyst stage, we do biopsy 6 to 10 cells. Yeah, and because you don't have to be afraid. Fortunately, the embryo has it doesn't damage the embryo. So I think maybe there's a little misunderstanding from side of the patient who asked the question. So we do more than a double biopsy. We do at blastocyst stage 6 to 10 cells to decrease the risk of a false negative. Yeah, but exactly that's the point. That's the topic of mosaicism. Yeah, just to scratch the topic a little bit. Imagine, at blastocyst stage you have 150 to 200 cells, and we do not know. We do not know which from the outside. We don't know what cells we biopsy. So imagine, and I'm simplifying now. 80% of the embryo is normal cells, 20% is abnormal cells. Imagine by chance we take the biopsy of the 20% abnormal, and we would diagnose the embryo not to be transferred. But 80% is good, so that's an embryo who can balance these little amount of abnormal cells. So we throw away a good embryo. Imagine the other way around. 20% of the embryo cells is normal, 80% abnormal. By chance, we take the the cells, the biopsies of the 20% normal, and we falsely transfer an abnormal embryo. That problem of mosaicism is not really solved, and it's a big issue. And so that would be my answer to that question.
Thanks so much, of course, again. If you would like to add anything, of course, go ahead, type this in. And in the meantime, we did receive another question. What causes biochemical pregnancy mostly genetic or endometrial issues?
Mm-hmm. Again, that's a black box. On the biochemical pregnancy, same thing. Why do embryos not implant, or why do they implant and then result in early loss? We don't really know. Obviously, a big part of it, a big chunk of it, is genetics. Now, especially in advanced maternal age, we know, from 40 onwards, we know that 80% of the embryos are genetically composed of not normal cells. So the biggest number of problems apply to the genetics in that age frame, or age bracket. Then another factor is endometrial. But there are tests on the market. We can check the endometrium. But even there, even if you have a perfectly tested endometrium, some perform error tests, and if even everything is synchronized with a perfect blastocyst, even a blastocyst after PGT-A, you can have a biochemical pregnancy or non-implantation. So it depends on age again, yeah. But with advanced age, the biggest part account for genetics rather than endometrial issues.
Well understood. Then again, of course, and yes, you can ask one more question, of course, no problem. And this is the question: is total fertilization failure an indication of poor quality?
Depends, obviously. Again, if the sperm is normal, yeah, then yes, a total fertilization failure can indicate poor quality. There, dig deeper into if it's advanced maternal age. If you have a patient 40 plus, yes, then total fertilization failure with normal sperm, normal for ICSI, indicates an oocyte factor. Another important part of the answer, to give you an idea, yeah, of we have total fertilization failure even in the context of egg donation. I give you the best case scenario, double donation, so perfect sperm plus perfect eggs. From scratch, one would tend to think that should be perfect. That should give us 100% fertilization and 100% blastocyst development. No. In the context of double donation, where everything is optimized, we in our clinic, and that should be in line with most other clinics who do that, we have a 2% ratio risk of having no embryos, 1.2% total fertilization failure, and 0.8% of the 2%, there's no embryo development. Yeah? Even with perfect eggs plus perfect sperm. And that kind of gives you an idea for the question you asked.
Yes, indeed. And it might look that that was our final question. But of course, as always, remember that Dr. Abraham, I'm sure, will be happy to help you out. You can just get in touch with the Eugin clinic, and I'm sure they will be able to help you out with any questions that you might have. So it looks like we will be finishing for tonight. So thanks a lot, everyone, for your amazing questions. As always, you never disappoint. Very detailed answers for sure, Dr. Abraham. Thanks so much. And as you can see, patients really appreciate that. There's a comment from Kat. Thank you for taking time with all the answers. There's also one more right here. So we will be finishing. But Dr. Abraham, if there's anything you would like to add?
No, I thank the audience for the nice answers. Actually, were quite interesting, and some of the answers, some might be even interesting for the patients who listened and didn't want to ask, because there were some quite interesting answers where I could give some information which was not part of the presentation. So that's a compliment to the audience. Very nice answers. And again, as you said, if there is other more detailed questions, they can contact us. There's no problem, whatsoever.
Amazing. Thanks so much indeed. And I do believe that was very valuable and that was very interesting for all of you. Thanks so much for joining us. And let me just mention, it has been recorded. So if you would like to have a look, you can always find it on My Avi Advances. It will be available tomorrow, also on our YouTube channel. If you subscribe, that way you will be notified that the video has been uploaded, of course. And I can only encourage you to join us tomorrow. We will be back at 7 p.m. UK time, actually. We will discuss success stories and recurrent miscarriages. There is another expert from Greece this time, so you can join us and find out a bit more as well. Dr. Andreas, thank you so much. It's always great to have you. I'm glad that you are back with us. So thanks a lot. Have a lovely evening, everyone. Dr. Andreas, till our next event, as always, of course. I'm already looking forward to it for sure.
Thank you very much. Thanks all.
Thank you so much. Take care.
Bye-bye. Take care.
Bye.
Bye-bye.